So this is our QI journey, and we are at a point where we were not able to synthesize in a poster because we are quite at an early stage yet on our QI. Let's see if that works. Oop. So our purpose when we came to this training was to develop our ability to improve our patient care, and we started this QI training as a team alongside with um, getting involved in a study special unit in the University for QI for medical students, which shows that we were really interested on that. And we went to Bristol because we wanted to know different teams. So we are quite in contact with our local teams around us, but we were really interested in looking at other teams, seeing other people. And at the beginning, we probably made the mistake of having so many projects, partially because we had 6 medical students to spoon feed QI. So our first project was to improve our impact through contact, particularly for this group of patients. So this is 5 years of our HbA1c result, and you can see we seem to be getting better to the really well controlled. We seem to be reducing the high HbA1c patients, but these patients between 58 and 68, they're not too bad, not good enough. They seem to be slightly neglected because we have been focusing on these ones. So we were interested in targeting these patients. And in order to keep the students busy, we started a second project with the aim to reduce the DNA rate in our multidisciplinary clinics, which means the hospital clinics, with the understanding that DNA is quite a bigger thing than just not showing to your clinic. So regarding the first project, Improving Through Contact, we ran our first PDSA. We created a way to identify patients. We allocated 12 patients to PDSNs, and we gave complete freedom to PDSNs to decide how do they want to improve their contact. And as we share in our last face-to-face meeting, there was a high variability both in patients. So we talk about apples and bananas, the resilient families and the very vulnerable families that obviously need different, but there was also huge variability in the PDSN approach. So some of these patients got 1 additional contact and some others 11 additional contacts. And guess what? Only 4 improved their HbA1c, and there were not the ones with 11 contacts. They're the ones with 1, 2, 3 contacts. So we thought there has to be a different way to do this. And then COVID came. So we obviously stopped thinking about it, but this is what happened in our service in terms of contacts. So you can see here, there's the 4 trimesters. This is before COVID. This is after COVID. The blue are the consultant clinics. The consultant clinics remain exactly the same, but were delivered by telephone. So they were all telephone or video, but we managed to deliver the same amount of clinics. You can see the green is the home visits, and obviously that was reduced, but that didn't come to 0 because in a diabetes team, we cannot avoid home visits. Some patients need a home visit, COVID or not COVID. This blue, dark blue, is the PDSN clinic, so the specifically led by nurses clinics, and there was a significant increase on that. And the reason is, in our team, the nurses sit in a different building, and the wards and the consultants are in the hospital. So the nurses being in the Child Development Center became a strategic advantage, and patients were much more happier to go to the CDC than to come to hospital. So that developed the ability of our nurses to develop specifically led clinics for patients. And finally, the red ones are the PDSN telephone clinics. Sorry, can I ask the PDSN telephone clinics or call or telephone contacts? And you can see that was expanded, that was double, if not triple. So guess what? We can increase our contacts with patients. We can do that. Um, we need to think, and this is what we're doing, more contacts doesn't mean more effective. We need to consider when a contact is meaningful, and this is what we're doing now. But we also identify two areas of difficulty. We struggle to sustain an MDT approach at the moment, and we struggle with the input of psychology and dietitians. So we need to become more homogeneous in the way we need to change on that. And we need to define what's meaningful contact. You could imagine some of these contacts are a highly qualified PDSN nurse talking through the phone with a family about how to download. And this is a massive waste of talent. That should be done not by a very expert PDSN, but by someone who is expert in downloading and in training people with technology. Okay, so this is one of our problems. So moving to the second phase, we have decided to get more structure, and the nurses decided to do a child development center nurse-led education clinic that will have longer appointments to be meaningful, that will happen between the two consultant appointments, and probably we're going, and this is still on we're designing that, it will be theme-based. What does this mean? Every trimester, the whole team will focus on one idea. So this trimester is going to be hyperglycemia. So correcting factor, sick day rules, high sugars. Next trimester will be low sugars, and then it will be diet, and then it will be whatever. But everybody will work on the same concept, on the same theme for a trimester in any setting. It doesn't matter if it's with your dietitian, with your consultant, or with your nurse, we will be focusing on that. So an initial capacity to do that is 12 patients per month. We need to improve our use on Twinkle to communicate. First clinic is on the 4th of October. First theme is hyperglycemia. And we still need to redefine how to reassess this and how to get patient feedback. But hopefully the QI meetings are now ingrained in our team, so that will continue evolving. With regards to the second project, reducing DNA rate, this is where we allocated the year 3 medical students. And if you think about it, 6 medical students on a team of 8 or 4 nurses, we were completely overwhelmed. So that was really not a good idea. We were not mature enough to have all these people around because they need something very simple and very structured, and we were not in that position. But we asked half of them to do for us a run chart, and they came up with this with a little bit of historical perspective. And this is where we started our QI journey with you guys. And what we learned from this is that people don't DNA in peripheral clinics, so the venue is important. People DNA in school holidays, or these are summer holidays or Christmas holidays. So we need help to manage that. And we wanna think that as the team has been consolidated in the last 3 years with new people coming to us and ingraining in the team, things are getting better. We ask another 3 students to do a poster in clinic to help patients to reflect about DNA and to ask for feedback. They come up with a poster that it was different than we expected, but guess what? That was last week. The poster is still there. So they definitely learn how to go through clinical governance, to infection control, so the poster is still there. And this is some of the feedback patients gave to us, which is some nice feedback sometimes, but also they're telling us this was quite impressive for me. So that's definitely not true. They see diabetes professionals all the time. We phone them, we see them in the CDC, we go home, but they don't perceive that. They don't perceive all members of the team equally, and we need to work on that. So moving forward, when COVID happened in this context with the medical students and the posters, and so what happened is we moved to telephone suddenly. So all the reluctance for telephones and download it suddenly disappeared because we just needed to crack on, and we made a great effort to engage and train families, and we are much better now using downloads. We even managed get DSN approved by the trust, which, believe it or not, has cost us like 6 years, 8 years. Now it's approved, but we don't still have it physically available, and that's another learning. So we don't have it, but we use it, full stop. And the other thing is, the CDC became our strategic advantage. It's a green area, it's centric, so we might need to think about it. And when we analyze what happened with our DNAs in the last year, so we started our QI here. This is our DNAs in hospital, in the MDT clinics. This is post-COVID, okay? So that's BC, PC. Post-COVID, we have reduced our DNAs, but that's difficult to interpret because we're not doing the same clinics. Our clinics are telephone. So if you want to see, and obviously home visits have reduced a lot, but not disappear. And we have more DNAs in the face-to-face appointments with nurses because we have much more nurse-led clinics and nurse-led appointments. So that's kind of our counterbalancing, okay? So you can read that in two ways. You can say, woohoo, we have reduced 30% DNA in hospital clinics. That's a way you can sell this. We are looking at this very carefully because what happens is we've seen with many things in our society and also in our diabetes teams, the social gap gets bigger. The apples get more shiny and the bananas bruise even more. We think, as Tricia was saying, you need face-to-face, you need body language to really train people and to really upskill families. We struggle with MDTs, and there's a group of patients that, I'm sorry to say, they need a face-to-face clinic, even a home visit. It is imperative. Those with safeguarding concerns, those living in deprivation, those with learning difficulties, no matter what manager says, they need face-to-face. So far, this is where we are. We think face-to-face is still the gold standard, and we are happy to adapt as much as we can, but we need to find what's meaningful and what's useful. Telephone for telephone means nothing to us. It just needs to be meaningful. We definitely need to get better at this, to work with the trust, to be more flexible. We are not flexible. The booking center doesn't work for us at the moment, and we don't really know how to make that better. We might need to consider new venues. Do we need to move completely out of the hospital? We would like to have more peripheral clinics, and we definitely need an admin support. It's a waste of talent. We have our nurses doing things that could be done by someone much less qualified, so we need to get on that. Something we have been even able to touch, I think, is the real issues. We haven't been able to think in terms of DNA, in terms of qualitative understanding of why these patients DNA. We know there's a few bunch of our families who DNA again and again and again and again, and we haven't been able to identify their needs and how to tackle. But I'm guessing this is not going to be a very quiet winter, so we're going to leave that for next year. And this is our journey.